Good afternoon to everyone. We'll wait a few minutes before we get underway with the talk as people log on, and then we'll commence with our last webinar. Okay, I think we will begin. So thank you for joining us for today's webinar, Principles of Nursing Education in Burn Management. My name is Dr. Miroslava Romach. I am a psychiatrist and co-director of the Ukraine Pediatric Fellowship Program, which is situated at the Hospital for Sick Children in Toronto, Canada. I'll be acting as the moderator for today's session. This webinar series is an initiative of the Ukraine Pediatric Fellowship Program, a program supported by Sick Kids Hospital to improve the quality of pediatric healthcare in selected children's hospitals in Ukraine. The series was organized in collaboration with our Ukrainian colleagues as part of our efforts to provide ongoing pediatric training while recognizing the unique and very difficult circumstances within Ukraine's healthcare system at this time. This is going to be the final session in our webinar series on critical issues in children's health in Ukraine. And as we wrap up this series, we're delighted to have had your engagement throughout the sessions led by experts in pediatric health. Before we get started, I'd like to go over some housekeeping rules. Firstly, our webinar will be recorded and we'll make the recording available on YouTube for those of you who are unable to attend live. Live interpretation between English and Ukrainian is available if you click on the interpretation button located at the bottom of your screen. It looks like a little globe, and choose the language of preference. If you wish to hear the interpreted language only, then just click mute original audio. You can ask any questions at any time using the question and answer function, the Q&A function on your screen. We'll try to get to as many of the questions as we can today. For any that we do not get to and are unable to respond to, please email them to Laura Lewis-Watts, whose email is in the chat section, and we will try and get back to you with the answer. So as I mentioned, this is the third of 3 webinars on the principles of pediatric burn management. And today we will have nurse practitioner Therese Kelly discussing the principles of nursing education in burn management. Therese Kelly received the nurse practitioner designation in 2004. She has worked at SickKids since 2000 and currently is the nurse practitioner managing the Burns Complex Wounds Unit since 2007. She has provided comprehensive care to patients and their families throughout the entire continuum of care. She is highly skilled at providing pain and anxiety management for this vulnerable population of patients, ensuring optimal quality of care throughout their entire journey while they are in the unit. She independently leads her own nurse practitioner clinic, where she effectively cares for her patients and families in collaboration with other members of the burn team. Therese has played a valuable role, having SickKids recognized as the first verified pediatric burn program in Canada, as well as creating the first pediatric laser therapy program for burn scar modulation in Canada. Theresa's contributions have been recognized locally by her peers as well as provincially, having received the 2012 Grace Evelyn Simpson Reeves Excellence Award and the 2013 Toronto Star Nightingale Award. So with that, I would like to welcome Therese Kelly. Thank you very much for your time that you've committed to sharing your knowledge with us.
Thank you so much for having me. I'm going to share my screen here and let me know when if you can see it.
Yes, it looks fine.
Yep. Okay. So thank you again for having me. Laura will be giving you my email address. So at any time, if you ever have any questions, I'm always happy to answer any questions at any time. Let's see here. Okay, so the objectives, I'm going to hopefully just go through some brief nursing roles and considerations when nursing these vulnerable patients, wound care and management, review the kinds of dressings that we use and that we have available to us, the frequency of dressing changes and why this is so important, especially in pediatric burn care. Go through a little bit about infection control and also pain management. That I'm very, very passionate about pain management, pain and anxiety management. They actually go hand in hand, and things that we can do to help support patients with this. With respect to the burn team, we do have a very small but mighty team here at SickKids. You know, it is a very well-known hospital around the world, but we actually have a very, very small group of people dedicated to burns here. And Helena was here and she could probably attest to that. We have our medical representatives, so our surgeons, our residents, our fellows, our anesthesiologists. We have our nurses that make up the majority of the team. We have a nurse practitioner, which is myself. We have a brand new nurse practitioner that we just hired. And our nurses in the OR, pre and post-op area, ICU, and up on the floor. We have our social worker that meets with almost every single family, and she decides whether she needs to stay involved or not. A dietitian to obviously ensure that the children are getting proper nutrition. Occupational therapists and physiotherapists that help mobilizing the kids, getting them going. A child life specialist, which is, in my opinion, crucial to the support that we provide our families, providing support to the child and the family through the hospitalization. A pharmacist that we work very closely with that helps us with our antimicrobial stewardship and lots of other medications. Our ICU team, and we do have a psychologist and a psychiatrist that we can consult on an as-needed basis. So these are some guidelines for burn patient referral, and you can find this information on the American Burn Association website. So if you type in www.ameriburn.org, and we can get you that reference if you'd like. They have some really great resources for burn care, and this will give you some information about guiding principles on what burns might be appropriate to keep in your center, or when you do need to be referring on to a larger burn unit. So with respect to the nursing role or being a nurse practitioner, definitely as an NP, a nurse practitioner, I do have an increased like a scope of practice. I can practice autonomously. I can admit patients and discharge patients, but I am a nurse at heart, and we have a lot of nurses, and nurses really can take advantage of our role to really enhance the care of patients and families. There's a lot of things that nurses can do. We coordinate care on the unit, and we can just advocate for that. You don't have to be an NP to do that. You can ensure that the right healthcare practitioner is there at the right time to provide the right service, advocating for proper care of patients with respect to pain and anxiety and itch, supporting children with their activities of daily living, making sure that they can feed themselves if they're well enough to feed themselves, and any kind of mobility helps with their inflammation and their pain management. Infection prevention is a really important one for nurses, as we are probably the most frequent visitor into a patient's room, and so we are the ones that need to be really, really conscious of our hand washing especially, and I'll go a bit more into this in detail later. Providing that wound care and the dressings, monitoring the dressings, making sure that they're in place. Do they need to be changed? Performing those dressings, so timing them appropriately, and providing supports for the children and the parents. There's obviously pharmacological things that nurses can do, but there's also a lot of non-pharmacological things. So sometimes we feel that our hands are tied with respect to medications that we can give, but what can we do non-pharmacologically that can help? Our child life specialist has a really important role with respect to this, but if you don't have a child life specialist, there are lots of things to do. A nurse can do something as simple as finding a cartoon or pictures that the child, if they have a pet at home, or things that they like to do, if they like to color, if they like to listen to music. Lots of little kids love Taylor Swift, so if they're feeling anxious, I might just pull up a Taylor Swift song. I try to attempt to sing a Taylor Swift song. So anything that we can do, blowing bubbles, slow breathing, imagery, distraction, anything that we can do to try to help relieve a child's anxiety can also help perceive pain in a different way. So it's really, really important. So it's just something to think about. With respect to nursing and burns, this is also what you might find that you would find on the American Burn Association website. It is a new course that they've created. It's certification in burn nursing. This is not a requirement, but it is something that the American Burn Association, the ABA, is encouraging nurses to do. I have not done it myself. But there are modules, and this is a great way to enhance your knowledge with respect to pathophysiology, the clinical management of burns, wound care, rehab, and psychosocial supports. So it's something to look into if you're really interested in burn care. So really important, if we're going to provide wound care, that we understand the principles of wound healing and the rationale. It's fine to do things, but it's really important to know why you're doing them. So with respect to burn wound healing, we want to make sure that we're providing adequate perfusion. We're minimizing bacterial contamination, and this is through just washing, however you choose to do it. We do it with soapy water. Minimizing the negative effects of inflammation, again, which is trying to prevent infection. Providing an optimal wound environment, which is by keeping it clean, ridding it of any kind of necrotic debris. We obviously clean our burns with adequate sedation if possible. Promoting adequate nutrition and fluid management. This is through proper fluid resuscitation if necessary. supplemental feeds if necessary. If you don't have supplemental feeds or NG tubes available, just ensuring that the children are getting oral supplementation through added protein if necessary. We always try to discourage drinking water and juice just because they're very high in, well, juice is high in sugar. It doesn't have a lot of good calories. It doesn't have protein. Water obviously is great for hydrating a child, but it's not good for caloric purposes. So something as simple as milk or chocolate milk, or if you have access to high protein beverages or Ensure, that would be great. Adequate pain management is crucial. If your pain is managed well, you can clean things well, you can put on dressings well, children sleep well, and sleep hygiene is extremely important for wound recovery and wound healing as well, and promoting reepithelialization. And I'll go into this with respect to the dressings that we use. This is just a little chart that we have in our clinical practice guideline. I put this together almost 10 years ago, just to give people a visual. Some people like to see words, some people like to see pictures, and it just gives you the characteristics of the different depths of burn wounds and the dressings that are suggested to apply on these. And I will review with you why we use these. And we also have a bit of an algorithm or a chart to explain what we do with respect to the initial care in the first 24 hours, and then we come back around 48 to 72 hours later, and we reevaluate the wound because we know that burns do evolve over time. What you see at time 0 is not what you'll see 2 days later. And 2 days later or 3 days later is when we will reevaluate it, thoroughly clean it with proper sedation, and apply one of 2 dressings. I will discuss the 2 dressings that we use, but we are by no means tied to these dressings. We would be happy to change to other dressings if we found other dressings that work just as well. We're always looking for better things, more effective things, and also cost-effective things, and I'll go into that as well. With respect to wound care, you're always wanting to think of these things when you're providing your wound care and your wound treatment. So you want to be minimizing pain, providing proper pain management, whether this be pre-medicating them or sedating them with analgesia as well. The extent of burn, obviously, the larger the burn, they might need to be sedated better. They might even need to be intubated in the ICU if it's very extensive burns. Location of burn matters as well. If it's a burn to the face or the peri area, we do not put closed dressings on these areas because obviously children are eating, they need to be seeing, they need to be talking and feeding. So we do open care to the face with Vaseline a couple times a day, and to the peri area, because they're in a diaper and their dressings could get soiled, we also leave these dressings open, pre-medicating them. We also sometimes even insert epidurals in order to manage the pain to these to the genitalia as well. And then using non-stick dressing so they easily can be removed as opposed to pulling them off and mechanically traumatizing the areas, and simple ointments to those critical areas as well. This is just a picture of a massive blister. There's a lot of controversy with respect to, do you leave blisters intact? And this is a perfect example of why you do not. So blisters there's pro-inflammatory mediators in the fluid that can actually continue to cause pain and inflammation to the area. The other thing is, one of the principles of wound care and management, not just burns, is that you need to assess the wound bed, and you cannot assess the wound bed if you have a massive blister in the way. You need to drain it. We will drain it with no sedation, because if you just lance the blister, it is not painful because that skin is no longer sensate. It's no longer alive. However, if we're going to deroof the blister and remove the blister, we would do this with the child asleep, because this would be extremely painful and we wouldn't be doing this awake. In some cases, you might not have access to sedation to do this. The only other alternative that I can think of that I've never done is possibly putting in a local in order to debride this. Local is not necessarily effective. It might not be that reliable. It might not hit the exact areas that you want it to. The other thing is having the child stay still. And that would be a problem because the child would still be awake. And if you're trying to clean and debride this area and like thoroughly apply a dressing, you might not be able to do that if the child is still awake and moving around. So really the most optimal thing is to have that child sedated properly. So at that point, we would be sedating them, thoroughly debriding that loose skin, assessing that wound bed. And in this case, it looks extremely pink and moist, and then putting on a dressing that will last for 7 days. Things that I would say we don't use, and I can explain to you why. The first is something like a wide mesh gauze, which is in the upper left-hand corner here. A wide mesh gauze will stick to wounds, and you have to pull it off. Wounds, as they heal and granulate, that granulation tissue will sort of granulate through all those wide squares, and then you have to pull the dressing off. You can try to soak it off, make sure it's like really, really moist and wet to try to remove it, but you can also choose to use fine mesh gauzes and they won't stick as much. Something on the right, like Medi honey, again, I have nothing against, this is just something I found on the internet, but any kind of honey in general, there are medical grade honeys that you can use. They do need to be changed every 2 to 3 days, which is why we would never use them, because our dressings need to be changed every 7 days. And so we really try to minimize the frequency of dressing changes to minimize that trauma that these children are experiencing. And it's also extremely sticky. So you need to be peeling this off. And we've actually had reports from patients that have had this used in other places that it's extremely painful to be removing. So we do not use this. And then we used to use Flamazine back in 2000. We used it up until 2007 or so. It's high concentration of silver, very good silver content, which is great for preventing infection. However, it can form a pseudo eschar, which can make it hard to inspect and evaluate the depth of the burn wound. It can also be inactivated in the presence of blood, and it also needs to be changed 1 to 2 times a day. So for these reasons, we do not use it because it's just way too painful for kids to go through these kind of frequent dressing changes. So I've been talking about silver. So silver-based products are the mainstay of the treatment that we provide. There are hundreds of them on the market. Silver is an antimicrobial. There's minimal risk of developing antimicrobial resistance. We refer to it as a closed dressing technique, meaning the dressing just stays in place for 5 to 7 days. You don't need to take it off. And then we remove it under sedation. We have chosen a couple of dressings that we sort of trialed a couple. There were reasons why we stopped using them. And now, as I said, we use these 2 products for partial thickness and full thickness burns, but we're actually in the process of trying to replace one of our products, and I can explain to you why. So the first one is Mepilex AG. So Mepilex AG is a soft foam dressing. It's impregnated with silver. And it's really important when you choose dressings that you understand the mechanism of why you're using it. So this is a silver foam. It is activated in the presence of serous fluid. So when you put it on a partial thickness burn, the silver becomes active and it will just stay in place for a week, and then you'll take it off a week later and it will be healed. And this is just a picture of showing how that works. And then lots of different silver dressings. We do use Acticoat, like I said. Acticoat, we put it on a deeper burn, which is a drier burn, and we will soak the Acticoat in sterile water, which activates the silver, and we apply it to the burn wound. And then we've sort of fabricated this installation of water, sterile water installation system into the dressing. We leave it alone for 7 days, and then we can change it once a week again. But there is a new product that we have found. It's called Exalt, which is another silver-based product, which is about 1/3 of the cost of Acticoat, and it works just as well. There have been cases of where people say that the application of the Acticoat can be painful because of the initial dump of that silver, and they do not get this with this Exalt product. So we are in the midst of trying to get this instead, and knowing that it's 1/3 of the cost, that could also save us money. All of these silver dressings are expensive, and you might think, oh, well, I don't think that we could afford this, but The cost of a dressing, an Acticoat dressing, which is $200, for example, it lasts 7 days of nursing care and dressings and supplies and medication and sedating. So it actually pays for itself pretty quickly. So it's definitely worth considering. With respect to choosing a product, these are all the factors that I consider when choosing a product. You want to make sure it's clinically effective, it's managing the exudate in your wound, it's comfortable, it's conformable, it's easy to apply, it's easy to remove. And biggest one for me is the number of dressing changes. So the fact that we can do 1 dressing change a week is pretty great. If I could put 1 dressing on for 2 weeks, that would even be better, but once a week we're pretty happy with. This is just do's and don'ts of first aid for burns. We do have our About Kids Health website. It's great for resources for burns, so you could always check that out too if you have any interest. With respect to infection control, I'm not going to go through this necessarily. I think we all know about the chain of transmission. We've got bacteria, and there's a reservoir and a portal of exit. There's a mode of transmission, a portal of entry, usually into a susceptible host. And in the case of burn patients, they've got massive open burn wounds. So it's really important that we try to protect them from getting any kind of infection. The most important is hand washing. I think we all know that. It's been proven to be the most important way to prevent infection. That's why we have bactericidal rinse outside of every room and inside of every room. Really important to be washing our equipment, washing down our stethoscope if you're going from room to room. You know, if you're taking blood pressure cuffs or thermometers from room to room, making sure that you're washing those down in between patients. So cleaning and disinfecting equipment, and really important to be donning and doffing that personal protective equipment properly, so we can make a big difference to the health of our and welfare of our kids. Because we know that there's lots of transmitted bacteria, and then also antimicrobial resistance with the overuse of antibiotics. We do not prophylactically treat children with burn wounds. We only treat them if it's clinically indicated. So I've mentioned that about hand hygiene and why it's so important, and when we're expected to wash our hands. And these slides will be available for you. The last thing I'm going to talk about is pain management, because it's really, really important. I'm very, very passionate about this. We know that there's different kinds of pain that kids have. There's the background pain, and this might be in a major burn. There's procedural pain with maybe face care, peri-care, any kind of minor, or in our case, it would be a minor wound care, because for major wounds, we would not be doing this awake. So it's really important that we be treating this in a timely manner, pre-medicating them for any kind of procedural pain management, and providing post-operative pain management as well. There's a great website called noneedlesspain.org, and you can go there to learn about pediatric pain specifically. We know that in the US that adults receive 2 to 3 times more doses of pain meds than children. We also know that the younger a child is, the less likely they are to receive appropriate analgesia, and they do receive fewer and incorrectly dosed analgesics in daily routine. We do work with a lot of learners here, residents and fellows coming from other hospitals, and we're constantly sort of re-educating them on the safety of providing narcotics and why it's so important to provide narcotics to children. There is an under-treatment of pain in children, and we also know that parents are looking to us and expecting that we're doing everything possible to manage the pain of their children. So we really need to be exhausting our resources and making sure that we're doing the best job. We do know that children do develop PTSD. So between 25 and 33% of burn-injured children do eventually develop PTSD or do exhibit symptoms of acute stress disorder. So we have to try our best to try to prevent this from developing. These are all just stated facts and referred to from evidence. Children that are hospitalized with an acute burn will frequently develop severe psychological reactions, and we see this quite often. And it doesn't even have to be a major burn. It can be a burn maybe 5% or 10%, especially when they come back to clinic. They have nightmares and flashbacks and behavioral regression. And we also know that the psychological intensity of burn trauma, it can actually be compared to inescapable shock or learned helplessness that have both been described in models of PTSD. So bottom line is, we know that if we can effectively manage the pain and anxiety, this can significantly reduce their stress. And here's another article from the Journal of Burn Care and Research. It was done with a group of 1 to 4-year-olds, basically concluding that the management of pain with higher doses of morphine could be associated with a decreased number of PTSD symptoms, especially in the first couple months after their trauma. So the gold standard for pain management is narcotics. We use morphine, we use hydromorphone. Hydromorphone tends to be associated with less sort of associated symptoms such as nausea and itch. So morphine is less expensive. So we do start with morphine, but we quickly transition to hydromorphone if kids are experiencing any kind of negative symptoms. We will schedule acetaminophen. There's literature to support that it is an opioid-sparing medication. So if we can put them on standing acetaminophen, we can actually give them less narcotics and then hopefully less side effects such as like that constipation or nausea or itch. And you can also give the addition of ibuprofen as well. So those are some things that you can do. This is just another paper with respect to, there's a couple just talking about scheduling acetaminophen, and this is not in a burn patient, but it's in other patient populations, showing that scheduling acetaminophen can be just as effective as narcotics. And then lastly, this relationship between morphine and the course of PTSD in children with burns. Again, just reiterating and reinforcing the importance of using narcotics and why it's so important. We do have a clinical practice guideline for pain in our CPG. Our CPG is about 40 or 50, 40 pages maybe, and it's very, very detailed with every single facet of care, emergency management and ICU and positioning and medications and wound care. And so pain is, as I said, a really big deal for us. So any burn that's greater than 15%, typically we'll just have them on a narcotic infusion, and we start with that scheduled acetaminophen. We will consult the pain team if need be. If our narcotic infusions are not effective, the pain team might put them on a ketamine infusion. Burns greater than 15% are typically in the ICU. Burns to critical areas, we will definitely be pre-medicating them before any kind of pain or wound care. And as I had mentioned previously, we'll even put in an epidural. This has been a new initiative over the last couple of years with burns to the peri area. We've had a lot of scald burns when kids are inhaling hot, steamy water after having coughs or colds, and they spill that hot water into their laps, and they have extensive burns to the peri area and buttocks. So that's been very helpful. And there's other adjunctive medications that we use as well, and these are usually started in the ICU for large burns such as gabapentin. And there's evidence to support that the role of gabapentin, it helps with pain and with itch. And clonidine, which is an antipsychotic medication, but in low doses can help with pain management as well. And very important to dose these medications correctly. As I said, some people are hesitant to provide adequate dosing. They're children, they're not sure they should be giving them narcotics. However, we dose our narcotics based on their weight. It's safe. I've highlighted this 0.5 milligram dose because for any kind of pre-treatment dose, we will give them the highest dose that we can. So for face care, peri care, any kind of procedural pain that we're anticipating, we will give them that pre-medication dose. As well, we will give them lorazepam if we think it will be helpful. Any kind of non-pharmacological strategies, as I mentioned, like music or anything that's distracting that might help relieve their pain and anxiety during any kind of wound care. And also that acetaminophen that really makes a difference. So that, for me, I wanted to make sure that I was sort of staying on time. Pain management, and I said, is the most important thing in my opinion, and the wound care. So the dressings and pain management go hand in hand. So if you can minimize the frequency of the dressing changes right off the bat, you're managing their pain better, you're keeping them comfortable, you're promoting wound healing by leaving these wounds alone and allowing them to epithelialize without being disturbed. That can really help with healing. So the last thing, I think that we all have an opportunity. Thank you for being here, first of all, because you're all making the decision to be here to learn or to possibly learn something new. I think that we all have an opportunity to learn from each other, grow from any kind of learning experience, possibly implement change and evolve our care, which can only enhance the care of our patients and families and hopefully improve their care in the long term. So I thank you all for listening.
Thank you very much, Therese, for an excellent presentation. We'll move on now to the question and answer section. And we really do encourage you, please, to post some questions. We're happy to answer simple ones, difficult ones. Please ask Charisse what is troubling you with respect to your patient care. We'll let Dr. Zoriana Ivanyuk start with the first question.
Thank you so much, Cherise. It was super interesting and informative. And first, I will start with my first question. Tell me, please, who is the first in your department who prescribes pain medication? Can it be the nurse who prescribes pain medication or narcotics, or it has to be the doctor's prescription first?
So in our burn unit, we have nurse practitioners, residents, fellows, and the staff, and the nurses. The nurses at the bedside cannot prescribe narcotics, but they can advocate for them to be prescribed if they feel that it is in the best interest of the patient. I was a bedside nurse when I started in 2000, and the reason why I became a nurse practitioner is one of the reasons is because I would advocate for proper pain management of patients. And I found that sometimes the doctors didn't want to order them. And I said, well, then I need to go become a nurse practitioner so I can take on this role. And I think what's also changed in the last decade is that the doctors have really changed their, I guess, beliefs in the importance of the nurse. I really do believe that the nurses are taking on a much more valuable role. I hope that they're becoming more and more respected because they are the eyes and ears for the team. You're at the bedside constantly. So to come to the team and say, these medications are not effective in managing the pain, and we'd like you to increase the dose of the narcotic, or we'd like you to start a narcotic. I think it's your job to advocate for this. And hopefully the model of care there is that the nurses and the surgeons work together in a collaborative fashion to provide that care to the patient and family. So as here, it is me who orders the narcotics, or the resident or the fellow or the staff. The nurses cannot, but when I order those medications, I say to the nurses, let me know if these are effective, and if they're not effective, let us know. I do a lot of education, especially with new nurses. When you give a dose of narcotics, you don't just give it and walk away. You give it, and then you reevaluate if it's effective. So you should always be reevaluating any intervention. So, 30 minutes to 60 minutes later, going back, how's their pain, rating their pain, and if their pain is still greater than 3 or 4, then it's not working. And the World Health Organization even has pain management guidelines as well. And whatever pain scale you use, typically the 0 to 10 is the easiest. With little kids that can't tell you what their pain is, I don't know what your pain scale is that you use. We have one called the FLAC, and I'm sure Fiona Campbell, I think she did a presentation, she might have mentioned it. The face, legs, activity, crying, and consolability, it's a score out of 10 too. And anytime a child's pain is greater than 3 or 4, we need to go back and figure out how we can alleviate their pain more effectively.
And I just add to that, Therese, how often would you do that? Obviously, a short period after administering pain medication, but how frequently in general do you administer pain assessment scales?
So we will assess pain every 4 hours. It's considered the fifth vital sign. So when you're doing your blood pressure and your temperature every 4 hours, you would also be doing a rating of their pain. And even if we've decreased vital signs to Q12, like every 12 hours, because a child's very stable and they don't need it, their pain should still be rated every 4 hours.
Thank you.
You're
And thank
welcome.
you for making that very vital point about the collaboration between physicians and nurses in terms of listening to each other's opinions and how to provide the best care. I think that's very important. Sorry, Zoriana, go ahead.
Не просто слухати, а ще й чути. Це дуже
Not only
корисно.
hear, but listen too. It's very important. And one more question about it. What about acetaminophen and ibuprofen? Whether a nurse without being a nurse practitioner can prescribe them too?
So here, the nurse practitioners and doctors prescribe all medications. It's not within the scope of a nurse to do that. I don't know what the scope of nursing in Ukraine, if it's different. I do know that there are areas in the hospital here where some nurses have developed medical directives, so they can actually administer acetaminophen, like certain things, certain medications they can just give because they've written out these medical directives and had them signed by their colleagues, their doctor colleagues. So that is something to think about. The one thing that might be helpful, because I don't know how hard that would be to do, is establish an order set for burn patients, for example. So every single burn patient, when they get admitted, they have every medication ordered PRN or as needed, so that you always have the option to provide it rather than you needing to ask people to order it, because that might be like getting medical directives for you to order it. It might just be a really difficult process to go through at your hospital, but making sure, like when a patient here is admitted, we just go click, 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 and they're automatically ordered Advil PRN, Tylenol PRN, morphine PRN, dimenhydrinate, diphenhydramine, cetirizine. Like they have every medication that they would need so that the nurses can use all those meds at their discretion. And then if it's a larger burn, we automatically order a narcotic infusion so that they're just on it.
Дякую дуже. І маємо питання таке.
Thank you so much. And the next question. How do you feel about alternative methods of pain relief for children, especially virtual reality, games on the tablet, or etc.?
I think it's great. We actually have a new role here. There's a child life specialist, and all she does is virtual reality with kids greater than 6 years old. And it's a brand new role, which is great. Before her, we sort of had to come up with these alternative distraction methods on our own. And I do believe that you need to use these. If you don't have access to pain meds, it's all you have, and you do your best to use these methods. But pain management, if you have access to medication, I think you should always use them together. I would never just pre-medicate a child and that's it. I always provide distraction. So even when I see kids in clinic, they're still nervous. And even if it's not painful, they're nervous coming to clinic because they have the experience of a trauma of having water scald themselves and having that previously painful memory. So even when I see them in clinic and I know that their burns are going to be healed, the kids are crying, they're scared. I give them some Tylenol, and I always provide distraction, whether it be, as I said, through pictures, videos, cartoons, looking at a stuffy, like a stuffed animal, petting something, different kinds of textures. We have like toys in the clinic. When you press a button and the lights spin, really simple baby toys. I remember having one when I was a baby where you press the buttons and like the little animals pop up and there's 5 different animals, and it's the simplest toy, and it's the one that the kids like the most. And so we have one down in clinic, we have one up here, and all of these simple things just to distract the kids or sort of attend to all of their other senses. It can make a really, really big difference for how they're perceiving what's going on. But if you anticipate something to be painful, you definitely need to give them a pain med in addition to those non-pharmacological techniques. But 100%, those non-pharmacological techniques are crucial.
Therese, can you provide just a very brief overview of the role of the child life specialist? I think that's not something they're familiar with in Ukraine and is relatively new even at Sick Kids, or maybe not.
Sure. So we've had a child life specialist on our unit for probably as long as I've been here, so since 2000. But the role is really exploding, and they have a lot more of a profile now, which is great because they do amazing work. So Maureen, who's our child life specialist, she does a lot of play with the kids, and she'll do a lot of like medical play and preparing kids for certain procedures. So for example, if they're going to have a dressing at the bedside and they're nervous, she can go in and talk to them about like what this is going to look like. So the child life specialist does nothing medical, like they don't do any medical procedures. There's nothing painful to what they do. It's all play and fun. So first of all, they also make sure that kids are playing games and they get them crafts and keeping them busy during the day. If we have to talk about skin grafting with the kids and they're of that age that they can understand, Maureen will go and prepare them for that and go through a storybook with them about skin grafting and use words that make sense to them rather than say we're excising the burns. Like they say we're going to remove the sick skin and we're going to fix your burns with new skin. And she sort of uses language that the child can understand. The child life specialist will also speak to the children based on their developmental stage. So she'll use toys and language based on their age. So if a child is in that stage of development where they're really, wanting to be autonomous, right? And they're struggling with the fact that people are controlling them all the time, she really tries to make sure that we're giving the child choice. She helps educate some nurses and informs nurses on, oh, by the way, I talked to Jane and Jane doesn't like this and Jane really likes when you do that. So, we're going to hold, she wants to hold her stuffy when you're going to do that, or she wants to listen to Taylor Swift when you do that. So she tries to incorporate as many non-pharmacological strategies for when we're doing things that are potentially anxiety provoking or painful. And she'll do medical play, like she'll bring in a little doll. It's like a doll with no face. It's just like a little like blank doll, really, really simple doll. And if the child has a bandage on, they'll bandage the doll. And as the child is getting less bandages, we remove the bandages off the doll. They can make a face on the doll that's happy or sad. So it's just also a way for kids to express their emotions, have someone to talk to. It gives the parents also a little bit of a break, because when Maureen goes into the room or we have a volunteer in the room, the parents might go get a coffee or take a walk because it's very stressful for them. So very invaluable role, really, really important. And sometimes when the child life isn't here, people will say, well, where's the child life? I need an iPad. But I think it's not giving them the credit that they deserve. A child life specialist is not an iPad. They're a lot more than that. And I think you have to take advantage of all the things that a child life specialist can provide. I can go get an iPad and I can go find a TV show, but there's a lot more, and it is an art, and there's a lot of skill that involved with what a child life specialist does. So that's in a nutshell sort of what they do, but there's a lot more information. If anyone was interested, I could also connect you with our child life specialist.
Thank you. And do they have to have special qualifications or specific qualifications to carry out that role?
Yes, so they have to have, it's a master's prepared role. I forget what it's called. It's a master's in child education or something. I forget what it's exactly called, but they have an undergraduate degree. And then there's a university in Ontario that a lot of them have gone to close by where they get this specialized degree in child development and hospitalization.
Okay,
Mm.
that's very helpful. Thank you.
Yeah.
Any other questions, Soriana? Or from our audience?
Станом на зараз в нас є подяки за надзвичайно.
As of now, we are getting more comments, but these are to say thank you for a very interesting input. We might have more questions in the process when people are watching this webinar on YouTube.
Any last points you'd like to make, Therese, before we start to wind up, or
Sorry, I didn't hear you.
did any, that's it for our questions that have been
Okay.
posted. Are there any final points you'd like to emphasize before we wind up?
I don't think so. The only thing I would say is if anyone is really interested in trying to improve aspects of the care and are interested in the products or want to know more about pain management or wound care or anything, I'm always happy to answer any questions. I can also point you to resources online that you might find helpful. There are conferences. I know it's hard to travel right now, but opportunities for learning, lots of webinars, lots of different ways to learn. But there is a yearly conference, the ABA, and there's actually a European one, a pediatric conference, the European Club for Pediatric Burns. And they have a meeting every year. It was in Toronto in September, which we hosted, which I would have rather gone to Europe. But next year, actually, I think it's in October or November, it's going to be in Amsterdam. But there are opportunities for smaller meetings, and it's a really great opportunity not only to learn, but also establish relationships with other colleagues in your community. So if, for example, I know that sometimes some of the major burns get sent to Zurich, for example. We know the people in Zurich well, but just a great way to meet your colleagues and continue to establish those networks, because even though we're proud of the care that we provide here, we're always wanting to establish national and international networks of people, because anytime we run into a problem, we want to be able to connect with people that might be able to help us. So it's always an opportunity to meet people.
Thank you. Well, thank you so much for joining us today, Therese, and for your wonderful presentation. Thank you to all of you for joining our session today. We have been uploading all of the webinar recordings onto a YouTube channel, both in English and Ukrainian. To view or subscribe to the channel, you can click on the link that Laura has posted in the chat, or you can scan the QR code on the screen. We've also made additional resources that were given to us by our speakers. We've put those into on Google Drive. And so perhaps some of the things that Therese has referenced today, we can also post on there. You can see the site there that Laura has posted. So hopefully you can find these additional sources of information helpful. So this brings us to the conclusion of the series of lectures on critical care matters in children's health within Ukraine. It's with gratitude that we acknowledge your active involvement in these discussions, and we extend our heartfelt thanks especially to the specialists in Toronto for generously volunteering their time and their expertise for this series. We hope these insights and resources will resonate and inspire positive change in promoting the health and well-being of children in Ukraine. We thank each of you again for joining us today, and hope to be able to continue with webinar series in this exchange of knowledge between sick kids in Toronto and children's hospitals in Ukraine. By continuing to work together and exchanging knowledge, we can make a positive impact on the lives of the youngest patients in Ukraine. So thank you again. Дякуємо.
Thank you. Bye.